So for colon cancer, eventually we're going to talk a little bit of history of intraperitoneal therapy. And interestingly, the very first instance that I could find of somebody using therapy directly into the peritoneum as opposed to IV chemotherapy or IV medications and things like that was this English surgeon, Christopher Warwick. He had a patient with severe ascites or fluid on the abdomen and used something called Bristol water and then actually a Bordeaux wine and treated the patient for the fluid, the ascites, the fluid in the abdomen for that. And that's the first time that I could find that anybody had ever heard of that. I don't know that it bore out because that never became a popular treatment. But in the kind of the 70s, people started doing, kind of resurrected this idea, at least, of, it's hard to get chemotherapy to the peritoneum, so maybe we can deliver it directly to those surfaces, kind of like spraying down the walls of the room, to use that analogy. And so the very first report of essentially Hipec, so thermal chemotherapy with a machine to perfuse that chemotherapy and keep it warm, for cancers of the peritoneum and the serosal surfaces. That was done for an appendix mucinous tumor by a Dr. Spratt et al. In the 1980s. And so the experience built on that, with Dr. Sugarbaker being a pioneer for cytoreduction in Hipec kind of throughout the 80s, and showing that it could be done safely and showing, at least in his experience, some good results. And so that led to a randomized controlled trial. These are generally our kind of gold standards for determining whether a treatment works or is better than other treatments or not. And this was done in the Netherlands, a randomized controlled trial for colorectal cancer that showed that compared to the standard treatment at the time, this is like kind of late 90s, it was published in 2003, compared to the standard treatment at the time, the patients that had cytoreduction and Hipec had a longer survival. And so that really, I think, opened up the field essentially and kind of revolutionized the way that we could view peritoneal metastases. We developed a scoring system to try to quantify the amount of disease. It's called the peritoneal carcinomatosis index, or PCI. The abdomen's divided up and the intestines are divided up into a total of 13 different sections, and then we score them based on a little bit of no tumor or a little bit of tumor to higher amounts of tumor, and a low burden of disease is a low PCI, so in the single digits, and then it goes up into the 30s is a high PCI.